Hello, I'm thrilled to be invited to present at the Mount Sinai Updates in Geriatric Medicine and Palliative Care. My name is Mara Cossetti, and I'm an associate professor of otolaryngology, head and neck surgery, as well as neurosurgery, and the director of the Ear Institute at New York Eye and Ear of Mount Sinai. And in this lecture, we're going to be covering hearing loss and aging. I have a few disclosures I want to mention. I do sponsored research with a number of implantable device companies, as well as serve as a research consultant for Acclarent. During this talk, we're going to be covering a number of objectives all related to hearing loss and aging. We're going to talk a lot about, not surprisingly, age-related hearing loss, the epidemiology, and especially the relationship between age-related hearing loss and a number of measures of health and function, most notably cognition or cognitive decline, social isolation, as well as falls. And finally, we're going to wrap up with treatment options. We're going to cover some of the new legislation regarding over-the-counter hearing aids and also talk about implantable devices and barriers to access. Well, this is no surprise, certainly to people in my field, but hearing loss worldwide is quite impressive. 466 million individuals with an incredibly large annual global cost. In the United States, this data is very similar. 2/3 of adults greater than 70 years old, and I would imagine that's a lot of individuals who are taking this course. Many of your patients fall into this. Hearing loss is the third most common physical condition of adulthood. And in fact, with the aging of the population, the proportion of individuals with more severe hearing loss is increasing. Probably you all see tons of slides with various demographics just like this. In ENT, we have a slightly different perspective, but we certainly recognize that the proportion of individuals within the largest age group are those affected typically by the most severe hearing loss. And in fact, that suggests that there are more individuals with more severe hearing loss living even longer. Let's talk just briefly about something that seems obvious or intuitive. What are the symptoms of hearing loss? Well, you might be surprised to find that the vast majority of symptoms of hearing loss are actually not hearing less. Most people, because of the insidious, progressive, and often bilateral nature of age-related hearing loss, it's very difficult to recognize. Sometimes you just don't know what you're not hearing. People often complain of difficulty in background noise. They indicate, sure, I can hear, but those people aren't speaking clearly. And in fact, it's that clarity of speech, which is one of the most frequent and first symptoms of hearing loss. Very commonly, people describe that something's stuck in their ear. They feel their ears are blocked or clogged. Sometimes that can be related to something like a flight or eustachian tube dysfunction, but oftentimes that's actually the first sign of hearing loss. Someone who's describing that they're having trouble hearing and their physical exam is normal may in fact have a sensory neural hearing loss. And lastly, tinnitus or ringing in the ear can be definitely a sign of hearing loss. We're not going to talk that much about it during this specific lecture, but important to recognize that it is also falling under the category of symptoms that relate to nerve-related hearing loss. So I'm a surgeon, so I love anatomy. We have only a couple anatomic slides here, so don't worry. Basically, this is just a diagram of the auditory pathway. So hearing loss can occur anywhere along this pathway, from the outer, middle, to the inner ear. And in fact, there are two types of hearing loss. Actually, three, if you count the combination. The first type of hearing loss is conductive. That involves, of course, the outer or the middle ear, and the rest is sensory neural. That's the inner ear, cochlear nerve, and brain. And certainly you can have both. You can have an ear infection and also have sensory neural hearing loss. This is basic stuff, probably covered in medical school, but it's helpful to remember that both of these can occur simultaneously. So individuals can have both infections that's masking a sensory neural loss. It's also important, and we'll talk about this in a slide or two, that age-related and noise-induced hearing loss are both sensory neural. Beyond being sensory neural, they're quite specific. They affect the cochlea, and that's a specific part of the inner ear, not necessarily the nerve of hearing and not necessarily the spiral ganglion cells, which are where the nerve interact with the cochlea, but oftentimes the actual hair cells themselves. So indeed, it's very specific. This portion of hair cells, this is that are lost with age-related hearing loss, and it's a very specific portion of even the inside of the cochlea. Later on, much later in this lecture, we'll talk about different treatments for hearing loss, but in fact, it's this very specific, if you will, rate-limiting step of hearing loss that occurs in sensorineural loss that allows things like implantable hearing devices such as cochlear implants to be so effective. In fact, those rely on indwelling spiral ganglion cells and intact nerve, which are preserved in hearing loss, but bypass these missing or damaged hair cells. These are quite visible, both, these are really nice electron micrographs of those hair cells and what they look like when they're in the damaged or lost state. The cochlea itself is a pretty amazing organ. I know most of you cover the literal entire body. Mine is much more narrow, just the ear itself. But of those things, the cochlea is just an amazing organ. So it is organized basically like the keys of a piano. We call that tonotopic organization, so that at one place in the cochlea, the base of the cochlea, is where the high frequency sounds are received, and that portion of the nerve is directly interacting with the cochlea, whereas at the apex is the low frequency. And it's the physical properties of the basilar membrane that allow all of these different firing in hair cells to take place. Well, how do you know if you have hearing loss? The gold standard for diagnosis of hearing loss is what we call behavioral audiometry, and that occurs in a soundproof booth. That can tell not only do you have hearing loss, but what type. It can tell between the types that I mentioned. Also includes a variety of measures called tympanometry, which have to do with middle ear pressure and function. And lastly, it detects speech audiometry, which is something that's crucial and that we use to help diagnose what types of hearing devices are appropriate. Age-related hearing loss predominantly and first affects the high frequencies, especially those in the area above 4,000 hertz. If you think back to a slide or two ago, I showed and I was talking about the amazing features of the cochlea where different frequencies are located in different regions. In fact, this high frequency portion is the part that is closest to the ossicles or closest to the middle ear. And it's believed that just the shearing forces and age in general lead those hair cells to be lost first. That's the mechanical mechanism and the one that seems to make the most intuitive sense to me, but certainly there's a ton of research in that area describing that both biochemical and molecular changes, such as pro-apoptotic and metabolic changes that occur with aging, start here in the area of the base of the cochlea, leading to why the most high frequencies are affected first. And it's notable that in many cases, noise-induced hearing loss and age-related hearing loss are very difficult to tell apart for those exact reasons. Noise-induced hearing loss shears off the inner hair cells or all of the hair cells, as does age-related hearing loss. And in fact, age-related hearing loss includes an accumulation of noise over the course of a lifetime. Here's a nice diagram of age-related hearing loss showing a behavioral audiogram that tests different frequencies, where the highest frequencies are showing the greatest amount of change. And again, typically age-related hearing loss is slowly progressive, bilateral, and often symmetric. This is just a comparison to reinforce that point with noise-induced hearing loss and age-related hearing loss showing very similar audiometric patterns. So is hearing loss related to other health conditions? I'm going to spend some time talking about this because it's a really interesting area that's highly pertinent to areas of geriatrics and the aging population. So the impact of hearing loss on health and function has been much greater understood with recent data from approximately the last 10 to 15 years. You can see on this diagram the relative large impact it can have on the diverse health and function of older adults. And we're going to talk specifically about a number of these in the coming slides. So let's begin with dementia. Studies from beginning in 2011 and extending up until almost today, which I'm going to show a few exciting slides about, suggests that hearing loss is a risk factor for dementia. And beyond it just being a risk factor, it appears to have a linear relationship, such that those who are affected with more severe hearing loss have a higher risk of dementia. This relationship between hearing loss and cognitive decline has actually been shown among a large portion of epidemiologic studies in the US and across the world. And in all of these well-controlled, large database studies with thousands of individuals, they have controlled for the many other factors that we know to affect hearing loss, just a few of which include various health functions such as tobacco use, cardiovascular disease, et cetera, and of course, age. So in general, compared with normal hearing peers, individuals with mild, moderate, and severe hearing loss have 2, 3, and 5-fold increased risk of all-cause dementia over 10 years of follow-up. This is just some specific data to, frankly, belabor the point that there's a linear relationship, we believe, between the amount of hearing loss and the amount of risk of cognitive decline. This is a meta-analysis that is a really thorough one that's been done recently that actually went through a lot of the prior data and was able to reinforce the concept that despite disparate measures of cognitive function, of course, the literature is rife, and importantly, had a lot of debate on how to measure cognitive decline and cognitive function in those with hearing loss, but this was able to synthesize a lot of data suggesting that despite disparate measures, all measures support hearing loss as a risk factor for cognitive decline and dementia, and consistently found that dose-response relationship that I referred to earlier. This data had been accumulating, as I mentioned, for the past 10 or so years, so much so that in their landmark studies, which are routinely put out, probably all of you are way more familiar with them than I am as a general rule, but the Lancet in 2017 and in 2020 identified hearing loss as the most important modifiable risk factor for dementia. In fact, it's one of the most important in the midlife, as you can see here by their really nice graphic, which goes over the different risk factors. When you look specifically at the numbers, the percent of reduction if the risk was eliminated was 9%. And for myself, I actually was able to, when you look, there's smoking is 5%. I mean, there are a lot of things that we immediately associate with dementia, and hearing loss is something that is now pretty well recognized as something that is critical to identify and think about when we're considering cognitive decline. Let's move to another topic, and that is social isolation and depression. And in fact, there's a lot of data to support this as well. Again, we see the linear relationship. For every 10 decibel drop in hearing loss, the odds of social isolation increase by as much as 52%. What underlies this relationship? Why are these two things related, these two concepts? We'll spend 1 or 2 slides discussing this, although this is very much an overview on a bulk of literature that has really delved into this topic over the last several years. So the first theory is one of cognitive load or attention, where there's a compensatory mental effort required to maintain cognitive function in the setting of hearing loss, because hearing loss is diverting or monopolizing those, resulting in overall decline. A cascade theory talks about a decrease in socialization, one that we know occurs just from the prior slide, but also makes intuitive sense, that individuals with hearing loss develop a decrease in socialization, which then in turn leads to cognitive decline. And the last one is common cause, where hearing loss and cognitive decline are the result of common neurodegenerative changes in the aging brain. So they are literally declining because of a similar cause at the same time. Again, lots of data to support this. These are just some very specific studies I thought illustrated this point very well. Hearing loss was independently associated with reduced volumes in the primary auditory cortex and the temporal lobe, and additionally was associated with an accelerated rate of whole brain and right temporal lobe studies, looking at neuroradiology data to help support that changes in brain and structure and function as a potential theory to explain or underlie this relationship. How about data to support common biology or etiology of hearing loss? Well, one of the many things, again, probably in all of your wheelhouses and not so much in mine, is the association between ApoE and hearing loss in older adults. And just to speak briefly about it, there actually, in a number of studies, there was no statistically significant association between that allele status and hearing loss. Certainly doesn't answer the question, but it's a piece of data that we're putting toward understanding this very clear relationship that exists. Switching gears to another relationship, and that's one between falls. Adults with hearing loss have a 63% increased risk of falls compared with their normal hearing peers. Again, enough data on this topic to warrant a meta-analysis, which again supported the concept that falling was much more likely in individuals with hearing loss versus those with normal hearing. Now, thankfully, I was not invited to give a lecture on this particular topic. It happens to be one of my areas of interest and research, where we try to better understand what exactly is contributing to this relationship between hearing loss and falls. And not to worry, I don't have a ton of slides on that one, but I would say we're just beginning to understand the relationship between balance and postural stability, which, by the way, exists outside the vestibular system to a great degree in these individuals, as well as issues of exercise and physical function, which seem to integrate well in terms of the way hearing loss affects the entirety of an older person's life. Lastly, just some facts that have also been pursued in terms of this large bulk of literature. Not surprisingly, there's higher costs that are affected by those with hearing loss. So individuals with hearing loss have a higher total lifetime non-hearing medical cost. They have higher rates of hospitalization, higher rates of readmission. Some of that actually has to do with medication compliance. Individuals may literally not be hearing the instructions and may not be able to integrate those into what they're doing afterward. And there's also been some studies looking at mortality where hearing loss had an increased risk of mortality of those with normal hearing peers. Again, in the majority of this literature, we're seeing that dose-dependent relationship where those with hearing loss who's more severe are affected in a more severe manner. So, does treatment of hearing loss impact these health conditions? This is a crucial area, especially for someone like myself who's highly focused on not only the diagnosis and understanding the impact of it, but whether or not hearing loss treatment can change these facts. So let's spend some time discussing this and then potentially even getting into a more broad area that relates to some of the changes and your patients may be bringing up to you. Well, before when I gave this lecture just literally a year ago, I had a number of slides that talked about how excited I was that this study was coming out. And so I'm really thrilled to be able to share the results with you. Likely you've all heard about these. This is the ACHIEVE trial run out of Johns Hopkins, where they looked at a 3-year study over a large percentage of individuals. It was adults aged 70 to 84 years old with untreated hearing loss and without substantial cognitive impairment. They were recruited from 2 different populations. One was nested inside an atherosclerosis longitudinal study, and the second one was de novo healthy community volunteers. This study aimed to identify exactly the question I posed in the prior slide, which is, does treatment of hearing loss impact cognitive function and the trajectory of cognitive decline? In this study, they gave individuals hearing aids. There was a tremendous amount of rigor scientifically in terms of how those hearing aids were administered and fit to target, and we'll talk about that in a couple of slides. But the ultimate results was they found that the hearing intervention, hearing aids, can reduce cognitive change within 3 years for adults that were at increased risk of cognitive decline. A deep dive into this study, which I have done and perhaps some of you have done and are very familiar with, reveals that the change in these study populations was specific to those or mostly seen in those who were in the nested cohort. So those who were at risk of cognitive decline had the greatest improvement. And not even just the greatest improvement, a quite significant improvement over a relatively short 3-year time period. Individuals from the community, those that had been recruited off of Facebook and social media, et cetera, with hearing loss, but who weren't at risk as determined by other comorbidities, did not experience a similar improvement or change in cognitive decline over that period of time. Indeed, when you speak with the study authors, as I have many times, 3 years is a relatively short period to examine cognitive decline, especially as you're thinking about it over a lifetime. And indeed, if they could do it for longer or many years, I'm sure they would. And I know they're thinking about extending those, but this was a 3-year time. And there's a lot of amazing things in this study related to a lot of different fields, many that they have not even published yet. This actually doesn't come as a big surprise because in my world, the world of cochlear implants or implanted auditory devices, we have known that cochlear implantation leads to improved cognition. There have been multiple studies that demonstrated an improvement of cognitive functioning in older adults with severe hearing loss after cochlear implantation. Now, a couple specific things that have occurred over the course of time in this data, and that is they used cognitive tests that were normed in hearing impaired adults. That's been a big thing. In many cognitive testing, the confounder of having hearing loss may affect the results. So in fact, maybe it's not that their cognition is changing, but actually they just have greater access to complete the test or complete the cognitive assessment. So that was not the case in these studies. In addition, many of these studies, such as the ones listed on the right, did non-oral or non-auditory based testing of cognition, taking that aspect out of it entirely. Based on all of the data that I presented earlier in the lecture that related to the severity of hearing loss, indicating those individuals were at greatest risk, this intervention is for those individuals who are at the most severe hearing loss and thus had the most potential to change or were at the greatest risk of cognitive function decline. Well, those two studies covered both hearing aids and cochlear implants. But in fact, there's a myriad of treatments for hearing loss. They can be quite dizzying, in fact, excuse the pun, for individuals who aren't familiar with this area, because just like technology is increasing and overwhelming, so are these options. So we'll just spend a couple slides on this. So of course, hearing aids, those are something we're all very familiar with. There's all kinds of different sizes and forms. There's not one kind that's the best. Patients often ask me, which one do we recommend? And in fact, there are multiple hearing aid companies and all are quite good and have excellent products. Mainly, many of you probably know personally or have had patients which indicate that their hearing aids just don't work. There are many reasons why a hearing aid might just not work. One of the reasons is how good was the prescription? And I make that visual analogy because I think it's sort of the most salient for many of us. We get a prescription for our glasses, and then how well your glasses are made to fit that prescription has a lot to do with how much benefit we get from wearing our glasses. The same is true for hearing aids. So actually a lot depends on the diagnosis, how well that hearing audiogram, that hearing test was performed, and how well the hearing aid is programmed to match that hearing test. So clearly, if they're amplifying things that already are not in an area that need to be amplified, and again, this pertains especially to those with age-related hearing loss, because they're not just turning down the volume in a very uniform way. Because of the underlying molecular and structural mechanisms of the ear that I went through at the way beginning, we know that the highest frequencies are affected the most. So these areas require more amplification than other parts of the audiogram. And how well that prescription, if you will, is fit to the hearing aid has a lot to do with how much benefit an individual might get from that particular hearing aid. Most hearing aids right now or previously were prescribed and dispensed by licensed professionals, audiologists, and required a physician to both order the test, much like you might order an EKG, you can order a hearing test, as well as suggest that they are medically cleared for hearing aids. The Over-the-Counter Hearing Aid Act, which we'll talk about in a minute, actually changed two things. One, it provided over-the-counter devices for those with mild to moderate hearing loss, and it indicated that use of a hearing aid or obtaining a hearing aid did not require diagnosis or dispensing by a medical professional. A lot of that related to the cost in an attempt to improve access and reduce cost, and we'll talk quite a bit about that in a slide or two. I put this up there just because even I get confused by these. These are personal sound amplifier products. You may know someone who goes hunting and uses them in their duck blind to hear better, or to hear the animals in the forest, or they may have just bought a really great hearing aid off of Amazon. And frankly, it can be often hard to tell the difference between a hearing aid and a PSAP. Basically, a PSAP is just turning up the volume. So unlike hearing aids, which can be specifically fit to amplify certain frequencies based on that individual's pattern of hearing loss, a PSAP just turns up the volume in general. And actually, for many people, can be quite effective. And because of the technology, they are much, much cheaper than many hearing aids. And here's some examples here, and they actually look a lot like hearing aids. So how about cochlear implants? Well, this happens to be my particular area of interest and research and practice. Cochlear implants are the most successful neuroprosthesis to date. We do them in babies as young as 6 months and elderly individuals as old as 90 or much older. We do them under local anesthesia for adults. And so definitely, while it does require a surgery, there's a lot that's being done in the surgical realm to bring this technology to as many individuals as possible. The way a cochlear implant works is by bypassing those inner hair cells, transmitting electrical impulses directly to the auditory nerve through a surgically implanted intracochlear electrode. The surgery, as I mentioned, is an outpatient ambulatory surgery, which can be done even under local anesthesia. So who is a candidate for a cochlear implant? A lot of my life and a lot of lecturing that I do is based on talking to others about this, but it's basically individuals who don't get adequate benefit from hearing aids. Certainly, the vast majority of people taking this lecture would definitely not need to know if someone qualifies for a cochlear implant or not. That is our job. But to know if they're wearing hearing aids, it's possible that those hearing aids are not well fit, as described earlier, or frankly, that they're just not strong enough. And the latter of those two things is a very common phenomenon, that these hearing aids don't work because they are not strong enough to address the degree of hearing loss that that individual has. And oftentimes that degree of hearing loss relates to clarity. Cochlear implants are good for auditory access and also for clarity. So far in this lecture, we've discussed that hearing loss is widely prevalent. We went through a number of slides that discussed epidemiologic data, both worldwide and in the US. We talked about the significant impact it has on health and function. We talked about cognitive decline, social isolation, falls, mortality, need for discharge care, et cetera. And we also talked about how it's highly treatable, both with hearing aids, including over-the-counter hearing aids, as well as implantable devices such as a cochlear implant. However, despite all of those things I mentioned, only 16%, that's actually quite generous. There are many studies out there which say anywhere from 7 to 16%, but some suggest up to 18%. Of individuals with hearing loss use a hearing aid. Even fewer, this says 7% here, but actually the data suggests even less than 5% of those with severe hearing loss get a cochlear implant. So that's pretty impressive. I mentioned how it has It's very diagnosable, highly treatable, very effective, improves hearing, as well as all kinds of other aspects of health and function. And yet very few individuals in this category are being treated. And this data is widely reproducible amongst many, many studies. So why is that? I'll tell you that the answer is more complicated than you might think. In this day and age of Zoom technology, I can't ask all of you to give me your opinions about why that is, but you could in your mind potentially hypothesize what could be some of the reasons for this. And I'll tell you that the most common one that people come up with is cost. And frankly, that's true. Hearing aids can be expensive. They're the third highest expenditure after someone's house or car. They're not often covered by insurance, and most importantly for this group, they're not covered by Medicare, and I'm not sure that that's going to be changing. They are covered by commercial insurances and often covered by Medicaid, depending on the state. But it was predominantly this issue of cost that led to the Over-the-Counter Hearing Aid Act, which ultimately came to fruition in October of 2022, after many lead-ups and a lot of amazing effort by a lot of individuals, both in the legislative world and in the hearing health world. So the goal of this new category of over-the-counter hearing aids was an attempt to break up the hearing aid industry to some degree, where there's predominantly 5 or 6 global leaders in that, to open it up for other companies and devices to come in here and lower cost. In addition, it provided 2 very important things, which I mentioned earlier, which is you no longer need a doctor's note or even a physician exam or diagnosis to obtain a hearing aid. Over-the-counter hearing aids are indicated for those with mild to moderate hearing loss. Now, how would someone know if they only have mild to moderate? We also talked about how it's very hard to know. Hearing loss symptoms can be quite insidious. And in fact, that's a bit of the challenges surrounding the Over-the-Counter Hearing Aid Act. However, if it's just cost and reducing cost, one might say, well, what about areas or in locations where cost is taken out of it? How much is hearing healthcare utilized in that case? Well, in fact, in England, where the National Health Service covers bilateral hearing aids, and in our own VA across the US, where hearing aids are covered, the rates of utilization are really not that much higher, or they're not even double. For example, they're 18% and 15% in some studies. And certainly in both of those cases, there's issues of access, but it really points to as there is in the US, which we'll get to, but it really points to the issue of cost and the fact that cost is not the entire message behind why hearing healthcare, or specifically hearing loss treatment, is not widely utilized. Of note, I showed very low rates of cochlear implantation, even less than 5% in our most recent data. And these are covered by insurance. They're covered by Medicare, by commercial insurance. And so these are not subject to the same issues of cost. So what is there in the barriers to care? What could be between these 2 things to help explain it? Well, the first one is that many people do not think that hearing loss is treatable. Actually, less than 20% of adults think that hearing loss is treatable at all. There's, in general, not only a lack of awareness of the options, not awareness of the fact that it could be treatable, but they don't know what those options are. Less than 10% of people have ever even heard of a cochlear implant. And frankly, I find that many who've heard of it aren't really sure if it works or not. And we're not going to get into that, but they are incredibly successful. Nothing is 100%, of course, but for the vast majority of individuals who are in that severe hearing loss category, they are dramatically helped by cochlear implantation. And the last one I find kind of interesting, because there was a really nice study that said adults are twice as likely to take their pet to the vet than to get their hearing checked. And I used to make really fun of that statistic until I got my own dog, which is, this is her cute picture over here. And so now I think I get it a little more. But regardless, it speaks to the fact that not only is there a lack of awareness of the problem, but a lack of motivation to even get treated when you get evaluated when you feel that you do have some hearing loss. Lastly, frankly, some of the problem is on us. Doctors don't ask their patients about hearing loss. You have a lot of things. All doctors have tons of things to ask their patients about. And frankly, hearing loss just doesn't rise to the top of the list most of the time. We won't get a lot into screening in this talk because that's a whole lecture in itself, but actually excellent data goes to show that one of the best screeners for hearing loss is just the question, do you think you have trouble hearing or do you think you have trouble with clarity? In fact, the answer yes to that question is remarkably predictive. So while there certainly are a lot of screening tools out there and various things have been piloted, myself included, in a lot of different environments, and that's excellent, even just bringing up the topic or asking a single question can have dramatic benefit in terms of that patient identifying or discussing their hearing loss. And of course, a lot of it is on patients as well. They don't bring it up to their doctor. Part of that is because we don't really medicalize hearing loss to a great degree. And so some people aren't even sure it belongs in a physician visit, to be honest. In fact, these are even individuals with hearing loss. 80% of patients with self-reported hearing loss have actually never discussed it with their physician. And it's also difficult because if they did discuss it with their physician and their physician didn't know a lot about it, that becomes uncomfortable as well. Of course, access. We really can't talk about any treatment option without talking about where access plays a role in terms of barriers to care. This is a nice map that a friend of mine just recently put out in JAMA Otolaryngology, which looked at the availability of audiologists, and in fact, even the availability of cochlear implant specialists across the United States. So we know that their access is definitely an issue. The last one that I really think can't be overemphasized, but for which there is not much hard data yet, is that of stigma. So use of hearing aids is really associated with getting old. Many patients, many cite cosmesis as the primary reason that they don't want to wear hearing aids. Much like many of you, I've had plenty of patients in my office in wheelchairs and in other things who just came from a rehab facility, but who didn't want to get a hearing aid because they thought it made them look old. So these are really deep-seated personal beliefs and cultural beliefs that we have to think about. Of course, we've known it for a long time in kids related to bullying, but it's really that concept hasn't been transitioned as we think about older adults. And frankly, when cost is an issue, it has to do with what people want to spend their money on. And the last part is one I'm going to spend 2 slides on, which is what about the language or the way we use to talk about hearing loss? Frankly, it's confusing. Mild, moderate, severe, what do these terms even mean in terms of how to imply what's the appropriate treatment? And that's a disservice to people that my specialty has done a disservice to the rest of medical field, and one that we're actively trying to fix. So this is something that is one of those things along that line, and it is the Know Your Hearing Number campaign. This comes out of Johns Hopkins, where incidentally the ACHIEVE trial and many other excellent pieces of data about hearing loss and health and function have arisen. And it speaks to the concept of improving the way people understand and talk about their own hearing. I didn't include this, but almost everyone knows what's a normal vision 20/20, what's good blood pressure. People even know what a BMI is. And these days, due to the excellent work of many of you, people know what a normal A1C is. And yet people have no idea what might be a normal measurement of hearing. Data suggests that it falls far below. They even know more about their pets, as mentioned, than they do about hearing for themselves. So the goal is to increase conversations about hearing loss among patients, healthcare professionals, and loved ones. And this might help to destigmatize and even medicalize hearing loss. And The ultimate goal is to empower people to adopt communication strategies and hearing technologies that can improve their hearing and their quality of life. So more to come on this. I very much hope that when I'm giving this lecture, if I'm invited back to do so, I'll have a lot more to say about the language and the staging system that we use to talk about hearing loss. So as a final few slides, I wanted to summarize a lot of what I'm saying with the comment that the impact of hearing loss on health and function is under-recognized and undervalued. Individuals wait an incredibly long time before they get treatment for this, and few even make that stage of getting treatment. And yet we know that that treatment can have a potentially very important impact on a lot of aspects of their health and also their quality of life. Certainly, this was the goal of the OTC Act, and it's the goal of many of us in this field to transition the future of hearing care from a high cost, low access to a low cost, high access. But we now know that just legislation or making hearing aids cheaper is not the only way to get there. And it really requires a change in thinking about how we educate both our patients and our colleagues about this concepts. And no hearing loss lecture is complete without the most important slide at the end, which is the best treatment is prevention. I didn't mention earlier that, in fact, those hair cells don't come back. Years ago, maybe more than almost 20 years ago now, they were able to regenerate hair cells in chicks, and that progression has not been rapid in our field, and I very much hope that that's happening in the future. But in the meantime, it's very important to protect your hearing, especially in midlife. So in conclusion, age-related hearing loss is common. It affects the high frequencies first, as we discussed. And because of this, and also because of the just slowly progressive insidious nature, the symptoms of hearing loss can be hard to detect. Hearing loss has tremendous impact on health and function. We covered specific data on cognitive decline, dementia, social isolation and falls, and other metrics of health and function. And we talked about how the treatment of hearing loss is effective, not only audiologically, which actually I didn't cover much of, but is tremendously effective audiologically, but also in terms of many of these other health functions, most notably cognition. And we spent a lot of time finishing our lecture about how it's greatly underutilized in all aspects, both those who are at less risk and those who are at severe risk, but those are the most hearing loss. So the legislative impact, like we talked about, the OTC Act and other things of the impact is unknown, but I myself am very optimistic and look forward to being able to share those with you in future Mount Sinai Geriatric and Palliative Care updates. Thank you very much, and it's been a pleasure lecturing you today.